Good morning, those of you joining. We apologize for being a few minutes late. I'm going to give it a few minutes to let people come on in. And again, good morning, bienvenidos. We're thrilled to have you joining. And again, sorry, we're running a few minutes late. We are working on our closed captioning, closed captioner joining. In the interim, we'll be using Zoom and PowerPoint closed captioning.
Para las personas que desean escuchar la versión en español, por favor elegir el idioma oprimiendo el botón en forma de círculo donde dice español en la parte inferior de la pantalla. Gracias.
Thank you, Christina. And again, welcome and good morning to all of our live attendees today. We're thrilled you're here to engage in this exciting webinar titled Navigating Integrated Care Settings, a Primer for Behavioral Health Providers. I'm Julie Chronister, and I am one of the hosts of our webinar today. My pronouns are she, her. I'm a white cisgender female in my mid-50s with light brown hair that reaches just below my shoulders. I have grayish black glasses on. I'm wearing a gray long sleeve shirt and my background is blurry. I'm a faculty member in the Department of Counseling in the Clinical Mental Health Counseling Program here at SF State, and I'm the PI on this project. I'm also working alongside my the project's co-investigator, Dr. Molly Streer, who is a faculty and coordinator of our school counseling program, and Dr. Tiffany O'Shaughnessy, who is faculty and coordinator of our marriage and family therapy program. I would also like to thank our graduate assistant, Christina Cabillas, who is working hard to stay on top of our technical issues, the chat box, etc. today. I'd also like to acknowledge that SF State campuses in San Francisco sit on the ancestral homeland of the Ramaytush Ohlone. We further acknowledge that we work on the ancestral lands and waters of many other indigenous peoples and nations in our field work in the Bay Area and around the world. We're committed to ensuring this webinar is accessible to our audiences. Closed captioning is available. We are still sorting that out, so bear with us. It will be available at the bottom of the Zoom, your Zoom screen. If at any time your access needs are not met or become not met during the webinar, please send a chat directly to a host or co-host. Access is always a work in progress, so we appreciate your comments, feedback, and support. This is our first webinar of the year. This is the second year of our project. Our project, Equity and Justice Focused Integrated Behavioral Health. And this is a fully funded project by the Department of Health and Human Services, Health Resources and Service Administration Act. A couple of things before we dive in. If you are a HRSA stipend recipient, i.e. one of our graduate students and are interested in receiving continuing education units, for your attendance today, please pay close attention to the announcements provided in the chat for sign-in and evaluation links. As a reminder, this is a live recorded Zoom webinar, therefore the audience is not visible and the audience cannot turn on their video or audio. The chat function is available for comments and sharing resources, supported emojis, etc. But to ask the presenter a specific question, please post your questions in the Q&A function, and Q&A will occur during the last 10 to 15 minutes of the webinar. Please post your questions as they emerge, and we will ask the questions to our presenters. If we can't get to all of them, we will pass along our presenters' and contact information. So it is with great pleasure that I introduce today's presenters, Kristen Potterbush and Julie Schultz. Kristen is a senior program manager in the Clinical and Quality Partners team. Kristen joined PCDC in 2019 to direct and grow a federal program for building the capacity of HIV/AIDS service providers, and currently works across initiatives to advance and promote integrated care, provide content expertise to federally funded high-impact prevention programs, and support other work aligned with promotion of health equity. Kristen's career is centered around the understanding that health begins before the healthcare center. Julie Schultz is a senior director on the Clinical and Quality Partners team. She joined PCDC in 2022 to support initiatives focused on primary care integration Prior to PCD, Julie held several executive leadership roles with community, provider, and payer organizations, developing and implementing strategy focused on value, delivery system reform, and primary care transformation. Julie has dedicated her career to working on innovative solutions within healthcare and communities that are person and family centered with a focus on equity. With that said, I thank you both for joining us today, and I will hand it over to you.
Thank you so much for that warm introduction. Hello, all. I am Kristen Potterbush. I am an individual in my 30s. I have brown hair and brown eyes. I'm sitting against a blurry background. I have a men's white collared shirt on and a gray sweater over that. I'm also having trouble navigating the PowerPoint. There we go. So the 3 learning objectives that we are hoping to address today are understanding basic principles of integrated care, identifying some of the ways that behavioral health providers such as yourselves can work to improve client care when you're functioning within integrated care settings, and hoping that we can support you in recognizing opportunities and strategies where you can build some of the strong communication pathways across the interdisciplinary team settings that you would work within should you be placed or choose to work within an integrated care setting. So the way we're going to approach this is to first give a brief overview of integration. Then we're going to talk a little bit about navigating the physical health landscape from a perspective of a behavioral health provider. We're going to touch on communication strategies and some of the billing impacts and operationalization impacts. And in the middle here, there's going to be a case study as well. So what is integration? Well, many on the call may be familiar or may have heard the term integrated health, and PCDC takes a broad and more responsive lens on integrated health, and we believe that it's truly a unified and collaborative approach to care that centers on people and communities. And ideally, integration achieves a more equitable and inclusive health system, helps achieve broadened access to care, and achieves improved health outcomes. And the reason that there is a picture of an apple and a picture of a Band-Aid on this slide is because I have a metaphor I like to use, which is if you walk into or you visit a drugstore like a CVS or a Walgreens, you're going to be able to buy both bandages and food products, be they a bag of chips, sometimes apple snacks. I've seen carrot sticks. If you walk into a grocery store, you're likely going to be able to purchase an apple and be able to also buy things like bandages. This is because systems like drugstores and grocery stores recognize that providing the kinds of services or goods in these instances that an individual needs makes sense because they're already present in that location. Now we can expand this metaphor out and talk about how if you have to travel a long way to that drugstore or grocery store and they only had an apple at the grocery store, no bandages, and they only had bandages at the drugstore, no apples, that you might be forced to make a choice. You might have to choose on that day, what did you need more, an apple or a Band-Aid? You couldn't go to both stores because of access issues, because of time issues, because of so many other components. And so what we're really seeking to talk about sometimes when we talk about integrated care is this radical notion that it takes more than one thing to help an individual be healthy and move forward towards a positive health outcome. And we want to provide all those components, all those collaborative approaches to care that center on what a person needs. We want to provide all the apples, all the Band-Aids, all the carrot sticks, all the shampoo and scrubby brushes that an individual may need once they're in the building. There are many facets, though, when we start to really talk about integration within a health system. There are models of integration, and some of those models include co-location, meaning that the one building has the behavioral health, the nutrition, the primary care, the oral health, the optometry that is needed. And that model sometimes just means that a single building, a single location has two types of service of care. So that building might just have optometry and behavioral health, or primary care and behavioral health. And that's sort of the co-location model. There are other models where folks are invited to come from other organizations and be present temporarily or on certain days at a building, and that can be considered co-located care or a satellite model. There are also ways to have very strong referral pathways. At the end of the day, there are a lot of challenges that organizations do need to overcome to make integration possible. And sometimes the model that an organization chooses can be equally reflective of some of the barriers they're working to overcome as it is the kind of care that they want to provide. There are also a lot of different pathways for providing integrated care. Some of those pathways include screening tools. So we have SBIRT, which I'm sure many folks on the call are familiar with, screening and brief intervention, referral to treatment, and adverse childhood experiences screenings. There's a lot of different mechanisms where you can start to bring components of integrated care into primary care environments. There's also principles that follow us when we're talking about integrated care. And those are things like social determinants of health or social impediments to health, SDOH. And there's also things like chronic disease management and other aspects that we're actually really able to stand up much more effectively when we're within integrated care environments. And we really want to make sure that we're remaining true to those. There's also, as you may have guessed, or as you may already know, different levels of integration. And this I sort of touched on in the previous slide around different models of integrated care, but it's important to know that integration is a continuum. And there are resources, and this is one that we happen to have up on our website, and that's the link if you want to explore this further. But I want to acknowledge that not every organization is going to be at the advanced level, and that might not even be where that organization needs to go as part of their integrated care journey. It's really, again, about being responsive to the folks that you're providing care to. So perhaps a strong referral network is really what your clients or the individuals you're providing care to would flourish within. And so it's identifying and choosing where you want to fall in terms of this continuum and making sure that all of the nuts and bolts are in place to make that possible. This impacts you as a behavioral health provider because you might come into an organization that is at a preliminary stage and hoping eventually to get to an advanced stage. And that might mean they're doing construction on a new part of their building so that more behavioral health providers can be a part of the practice. Or you might come into an organization that's at an intermediate level and they're very comfortable there and they're working to bring partners in and they're working to have some ability to perform some of the general health appointments. We oftentimes will see this at organizations that are behavioral health forward, that they might bring a primary care provider in part-time as part of a satellite system. So just being aware that you may, at different organizations, encounter different spectrums that folks have made the active choice to either stay in or they're on a journey to integrate further, and you've just met them while they're along their journey. So now I am going to pass the slides over to my colleague, Julie, to walk you through some of when a primary care provider can benefit from behavioral health providers.
Thank you, Kristen. Hello, everyone. I am Julie, and my pronouns are she, her, hers. I am a female in my late 50s. My hair color is brown, but graying, and it is shoulder length. I am wearing a blue shirt with some embroidery in the front, and I have a blurred background. It's great to be here with everyone today. And as Kristen mentioned, after talking about a variety of ways within healthcare settings that there might be integration, I'm going to move into specifically some areas in which behavioral health providers can engage with primary care. So some of the common areas related to behavioral health may be for a behavioral health provider to engage and support primary care could be related to diagnostic clarification or thinking about interventions and providing that type of support related to patient management. It could be a variety of different assessments or interventions. So some of it can be providing clarification, interventions, but it can move to actual co-management related to patients or providing services. So perhaps the primary care setting, there's not necessarily a need at the moment, but it shifts to behavioral health support. And in thinking about an adolescent setting, it may shift to also thinking about the family as well and providing some additional services as well as to the child or adolescent population. Some of the other areas can be thinking about medication management or medication response. And I would also include that it's a team-based approach to care delivery as well. So it's not just with perhaps the provider, the primary care provider, or the nurse practitioner and physician assistant. There's other team members who are associated with the care as well. So you may be engaging with a wide variety of staff members within the practice as well, in having conversations about patients. Next slide, Kristen. So some of the common medical issues, and this is absolutely not every issue that may come up. We wanted to focus a little bit related to adolescence. Some areas may be related to high medical utilization. There are studies that indicate that patients who tend to go to the ER and then end up in the hospital, sometimes the issues are related to behavioral health issues versus actual medical issues. So if there's an opportunity between behavioral health providers and primary care providers to set up a plan of care and work on that co-management of patients and the family dynamics, then that can that collaboration can impact that utilization of other medical services at higher levels of care. Other medical issues are medication adherence. If you think about adolescents, taking medications in the right way. If you think about asthma and the ways of taking the medication and inhalers correctly, there is the spacer and the inhaler. There's a right way to do it. In adolescence, however, there's a sense of wanting to control and perhaps not wanting to spend time and taking medication correctly and following all the steps. So stepping back and finding out what are those, what's stopping an adolescent from spending time and thinking about the diagnosis they have and wanting to spend more time on the treatment and what it means to them in terms of the medications that they're using. Weight management, chronic pain management, smoking cessation, other areas that can benefit from that really great collaboration and integration between primary care and behavioral health providers. Another area that not many people think about is insomnia and sleep hygiene. Studies have shown, and we have some materials on our website that we can provide afterwards that really talk about this area of that it's really compounded if there are some behavioral health concerns or needs that sleep can truly be impacted. And then there are true medical conditions, diabetes, asthma, cardiac conditions, other chronic conditions that can have some components of depression, anxiety, other concerns that can benefit from the integration of bringing the disciplines of medical in primary care and behavioral health together. Thank you, Kristen. So want to just step back and highlight to all of you that you are all key. Don't underestimate your value in these settings. Sometimes especially if you're in a new setting, it may be that some of the terminology is different and it may be a barrier, but it's really incredibly important to just step back, be partners with the other team members in this setting, to ask questions like we all do. There's nothing wrong with that. And because you will find that the other team members on the medical side will ask questions of you as well. And it will become a stronger partnership for asking those questions of each other. And we've just found that historically in the medical field, we've done something of separating the mind from the body, and know that that was something that we should have not done, and to have all of you and your skills be a part of the medical component of healthcare delivery, and really stepping outside of that and understanding what it means for patients and their families, and the fact that to deliver patient-centered care and think about individuals and how they engage in their communities and so much more broadly is such a support for individuals in their achieving their optimal health. I think is something, as a clinical person in the healthcare delivery system, we are learning so much from behavioral health providers and programs like all of you are a part of, that your lens and what you bring to healthcare is a critical component to really being able to provide such better medical care delivery. Next slide, Kristen. So I'm going to move into a case study and kind of talk through this a little bit. We won't have time to dig into maybe all the acronyms that I'll say. Some of them may be familiar to some of you, and some of them may not. And I think it just will surface that there's a lot of lingo that happens, and different provider offices may use different assessment tools. So there will be some different types of tools out there, but it just starts to have a conversation about different assessments and techniques that may be utilized, but start to talk about how behavioral health can be such a critical component. So we'll talk about MJ. MJ's 15 years old, has knee pain and a cold, but has a history of asthma and has gone into the primary care practice. At that time, it's been a while since MJ has been in the practice, so they decide to do an adolescent PHQ-9 So the adolescent version of the depression screening, and also a craft. So this is, Krista mentioned earlier, SBIRT, the screening, brief intervention, and referral to treatment. CRAFT is an adolescent version of that, of the screening tool. And it turns out that NJ scores mild related to PHQ-9. The team finds out that MJ quit soccer because of the knee pain, and reports that the relationship with the partner that MJ is dating is not going well. So there's starting to be some signs that some of the important relationships in MJ's life are not going well. There's a positive CRAFT score as well related to alcohol. So the primary care provider reviews the medical history and also finds out that MJ's father smokes cigarettes, which is exacerbating the asthma. The PCP steps back and realizes between some of the medical needs and the environment that MJ is living in, some of the things that are going on in the psychosocial life of MJ, the assessments and where MJ is scoring on those assessments. The PCP wants to bring in the partner of behavioral health as soon as possible, even though some of the assessments are mild, but earlier, bringing in behavioral health earlier is better than waiting to see things progress. Go ahead and change. Thank you. And part of this process is a physical exam. So the BMI is 23, a BP, blood pressure, 116/72. The pulse ox or pulse oximetry, which is measuring oxygen, which is important for related to the asthma and the asthma exacerbation. It happens to be fine at 98. When you think about some of these things, if you're engaged at a primary care practice, these are some of the physical exam and elements that being part of a primary care practice, you start to become familiar with and learn when is something in a positive range and when is something out of range. As I mentioned previously, the screening for the PHQ-9 was mild, the CRAFT was positive. Happened to be that MJ mentioned that he was drinking alcohol, and then in the rest of the CRAFT screening mentioned that drinking to make himself feel better. Also part of the report is the medications and the inhalers that MJ is on. Continuing the assessment and plan, MJ is on an asthma action plan. This is a plan that is standard for asthma in terms of having some control over how to use your medications and knowing when to increase your medications if you're starting to have additional breathing issues, and moving forward in titrating your medications in different ways. The PCP creates an updated plan for that and keeps MJ on the current asthma medications, but wants MJ to follow up in 3 months. Behavioral health, as mentioned before, referral for the mild screen and positive alcohol risk. MJ scored positive on both that CRAFT and PHQ-A. So having that integrated behavioral health, it becomes a no wrong door model in which behavioral health is right there. MJ can see a behavioral health provider while at the practice, have that conversation, find out how some of the relationship with the significant other is impacting, how not being part of soccer may be producing some additional anxiety, how perhaps some of the friends or influences at school are impacting MJ to think about using alcohol more so because of the other stressors and anxiety, and really bringing in the ability to have those conversations much more quickly than if there needed to be a follow-up referral. Slide. So just to bring everybody into the conversation virtually a little bit, and Kristen help me out here. In the chat, would love to hear from everybody what you think, the role of the behavioral health provider can play in this, case study. Pick the letter on the slide that you think how a behavioral health provider might engage. Go ahead and put it in the chat. No role, speak to the PCP, help the PCP with upskilling. It looks like Dana in the chat has picked C, and on the slide, we have what role do you think a behavioral health provider plays? C is a behavioral health provider can speak with the PCP during the next case consult about MJ's mental health, may intersect with MJ's care plan, and both providers can agree to collaboratively centering MJ's care around a shared set of patient-centered goals informed by MJ. Lots of C's coming through the chat. Anything anyone would add that you might add to? Saba has put into the chat that A is not one to pick, which is behavioral health has no role beyond addressing MJ's depression or SBIRT score. Several participants are putting in multiple responses, combining responses, adding to follow up on substance use, making a connection in California with CalAIM. That's excellent. Great. I think all of these answers are really good. I think you're identifying really the broad nature of how behavioral health can truly engage in a practice. And as the care plan evolves, the engagement may evolve as well, and to stay connected. So really appreciate everybody adding in. Thank you. So common health conditions, one may be diabetes. We didn't talk about that in the use case today, but there's some language about that. A1C, or it may be called hemoglobin A1C. You may see that terminology. You're not diabetic if your A1C is below 5.7, but if it is above 6.5, that's considered to be diabetic. And there may be some other terminology of home glucose testing, or you may hear terminology, especially from families, maybe not so much the healthcare providers, but sugar tests, asthma, language associated with asthma could be inhalers, ease of breath, but those can be also associated with panic attacks versus asthma attacks. It could also be that it's associated with exercise, and it may ease up as a child gets older. So it may be something that they grow out of. Related to pain, it could be treated with physical therapy or associated with SRIs, and pain is associated with treating with opioids that can be associated with substance use disorder now. So really a lot of focused attention on how the pain is treated, conservative treatment versus medication, and then leading some practices into MAT treatment as well. And then sexual health, sexual and reproductive health, PrEP treatment, for example, being associated with that. So there are a lot of different sort of chronic health conditions that can really be extended into a variety of other areas that then are supported by all of you and your skill sets. Let's see, I think I am transitioning back to you, Kristen.
Well, thank you so much for that, Julie. And as many of you in the chat all selected, there are so many ways per that slide that Julie just went over around how behavioral health will need to interface with, or can upskill, can offer support, and be such a critical part of, to use the case study, for example, MJ's health. But you and the primary care provider or the other members of the team will need to communicate around MJ's case. You'll need to discuss those positive CRAFT scores. You'll need to potentially understand more around the environmental factors present for MJ. And you as a behavioral health provider might want to provide some supportive coaching to the primary care provider around how to continue to support MJ through both the asthma action plan and also potentially some of the emerging pain issues that MJ may be experiencing. And all of that means that you and your team members are going to need to have a series of conversations. And I think it's really important, and we at PCDC very much believe that one of the corners of integrated care being successful is interdisciplinary teams communicating well. And to do that, we like to back up a little bit and acknowledge that we are all human here. Even if we put on white coats or we sit in offices and, speak with folks, we also still bring our experiences into those rooms and into those conversations with our colleagues. And there are some factors in how we communicate with each other. It can be that we're trained in different ways. For instance, primary care providers do receive different kinds of trainings and different ways that they communicate with each other than folks who are in behavioral health. Also, we all communicate differently when under stress. We might have insecurity. There might be historical disrespect between provider types. There are also power dynamics and privilege. And there's so many different factors that go into the effects of our communication within our provider professional spaces. And oftentimes that can show up with missed opportunities for preventative care because team members aren't able to really have that strong conversation about what MJ needs. There can also be things like lowered medication adherence, the missed opportunity. Maybe the primary care provider wasn't listening or engaging with a behavioral health provider who was letting that primary care provider know, hey, this is how I recommend that you go about, providing support for this client to make it easier and more likely that this individual will take their medication. And so it's really important to take that step back to understand how we can go forward. So one of the ways that we can move forward is by doing activities and using tools. And I don't need to tell all of you on the call today, about communication tools and tactics. I'm sure that many. This is simply one that, I've been speaking about with individuals that are part of interdisciplinary care teams because it's simple and easy to do. And you can do it with the team, or sometimes you can do it as a personal thought exercise just to understand what's going on in the space. And so I like to call it stop, start, continue. And for instance, it calls upon you to put an action in. So something like in daily huddles or in case consults, or even, when a behavioral health provider is asked to step into the room with a primary care provider in front of a client, you can identify what you want to stop doing. So the example I used here is in daily huddles. And this is taken from an organization I worked with. So, assuming that all providers in that space know the same acronyms. At that organization, there were peers, there was a nutritionist, there were some primary care providers, and there were mostly behavioral health providers because it was predominantly a behavioral health provider organization. And it was becoming a little tense in those huddles in the morning because nutrition was using different acronyms and primary care was using different acronyms and behavioral health was using some acronyms, and not everybody knew each other's acronyms. So people were sort of talking past each other. And then, what do they need to start doing? And sometimes, to reference the past slide, you have to take that step back. And one of the things that this organization was interested in doing, well, I should say open to doing, was trying to help folks practice communicating with each other about who they were as humans and not just assuming that you could start while you were already on the road. So to do that, they were just going to do sort of a rose and thorn activity, which is what I call this sort of, practice of, you say one good thing that happened over the weekend, usually because it's a Monday, and, one thing that, is sort of weighing on you or might be a difficulty. And then on Friday, you could say something good that happened the past week and, something that maybe was a challenge or a difficulty the past week. And that can get you to sort of build that camaraderie. And then also you always want to acknowledge what's going well. And so acknowledging, what do you want to continue doing? And they were already doing a great job prioritizing conversations around clients that really needed critical care. And that's actually something that I thought was really interesting, that when it was something that everyone could really rally around, people were able to put down some of that tension around communicating past each other and say, okay, it doesn't matter if I understand exactly what you're saying, or I think that you're talking down to me. We just need to figure out what's going on with MJ here. So this is just a tool that I invite you to use in your own mind, or potentially with any future organizations that you're with. You can also have it done by multiple folks anonymously or do it as a group activity. It just depends on what the ethos and comfort of the team is. So moving into talking about sort of the operationalization of integrated care, we didn't want to not acknowledge some of the things that you may encounter or may hear discussion of if you're within an integrated care environment. And some of these key areas are Stark's Law, which presents a gray area, especially for safety net providers, which complicates where an organization can refer and if it's possible for that organization to refer interorganizationally. That can impact you if you're co-located particularly, or if you're a satellite provider who's sort of brought in but not a key part of the primary care practice, for instance, that you're operating as part of. Also, some organizations are challenged to justify to payer organizations why there have been 2 different visits at a single organization that have been billed for. And this goes into a whole other conversation around sort of safeguards against fraud that sometimes can negatively impact integrated care settings downstream. Protections that were originally put in place to mean well, but now the way that they are implemented really can slow down making integrated care possible in some states. Sometimes multiple visits are needed before a referral can be made. You may run into someone saying, hey, I've seen a client, I'm going to refer them to you. They need X number of visits before their insurance will kick in. So just be aware, in 2 months, I'm going to send MJ to see you. Sometimes there are challenges around there not being existing behavioral health providers and not having the pathways or infrastructure. Some of you may have the unique privilege of being the behavioral health champion that is with an organization that is just starting to be along their integrated care journey. And there can be a process that it takes for the organization to be able to refer folks to you, even if you're right there. Also, sometimes clients can be maxed out as far as what their insurance will provide and pay for. And that's something that you might hear if someone says, okay, you're going to see MJ, but we need to wait a couple months until it's January, and then their insurance going to kick in. And then also sometimes, and this comes from a colleague of mine, there can be the need on EHR systems to maybe stretch the truth a little bit so that, it's a little bit easier to negotiate follow-up care. Maybe there's some ways to circumvent those 3 visits pre-referral if you put a certain diagnosis down. And those are conversations that you may have in some of those daily huddles. So just also to touch on billing, because billing, especially if you're within a primary care setting, may be different than you will encounter in a behavioral health setting, is that if you're within an integrated care setting, things are going to be very state or payer specific. And so that means organizations like managed care organizations or CMS, so Centers for Medicaid, Medicare, will dictate some of what's possible and what's not possible. You also may encounter that some of what's being paid for is going to be covered by grants, grants that might support screening tool use. Such as, I think in California, there's been a lot of support for screening for adverse childhood experiences. And there were some grants that went out that provided primary care providers with a little bit of cushion so that they could conduct those screenings. You may lead groups that have team members that you did not expect to join. For instance, smoking cessation groups in some states aren't billable unless there's a registered nurse or someone else who I think it's registered nurse, nurse practitioner, or an MDDO as part of that. So you might find that you're leading that group, but there is someone in the back who is sitting there participating because that's how that service is billable for the state. You may have impacts on collaborative documentation, how much time you're able to take for some of the huddles, some of the case consults may not be covered, and henceforth. So you'll also, as part of that, find that the culture around billing may be new. And there's really no way in the time that we have left to sort of cover all of what billing culture sort of can mean for you as a behavioral health provider. So what we really just want to recommend is ask. Because one of the reasons we can't cover it all is because it's so unique to an individual organization and how they handle billing and their electronic health record system and so on. So don't be afraid to step up and ask so you can prevent challenges long-term. Seek to understand what are the tricks and tips that this organization uses to make sure that they can provide the kind of care that they're seeking to, which would be integrated care. And sometimes billing departments are also learning the ropes along with you. So you may need to be prepared to be a little bit nimble. So, you know, when we're talking about integrated care, and I think this is, yes, my sort of wrap up slide here, we just want to sort of close with acknowledging that we believe that when you're within an integrated care environment, that kind of collaboration, it leads to quicker and more sustainable patient and client wins. And we see this in the US, and we also see this in other countries that have national health systems that have been able to mobilize integrated care approaches for a number of years now. It just makes sense when you're able to address all of the needs of a client, that that client is going to flourish in a more sustainable way. We also are able to provide a higher level of care for those same reasons. It also permits us the unique opportunity to really action responsive care. And that goes to sort of our definition of integration, right? We view integration as the way to provide the kind of care that the client themselves truly needs. We're not trying to invite a client into care that they don't find necessary. We're trying to provide the apples and band-aids that that client needs when they come through the door, to use what Julie said earlier, that no wrong door. And we also believe that integration allows for a strengths-based approach. It is very difficult to be a provider, period, let alone right now in our period of healthcare landscape history. When you are part of a team and not just going it alone, you aren't going to have to figure out what medical condition the client in front of you might have if they stand up and they're really dizzy. Maybe MJ stands up and MJ is super dizzy. You can refer MJ to your primary care provider in-house so that MJ's needs are immediately addressed. You don't have to play guesswork and call around. You can refer to someone right there who can then check back in with you, and you can team together to make sure MJ gets the care that MJ needs. Because when you work together, there's that opportunity to lift everyone's burden, and not just the clients, also yours as a provider. As a provider, you're here to action the kind of care and support that you believe people have the right to receive. And we believe that integrated care enables you better as a provider, as a behavioral health provider, to live into your vision of what you want your career to be. So just to wrap up, we want to thank you so much. And I know we have a couple, it looks like we have a couple comments or questions coming in. Want to leave time for those, but the slides I think will be provided. And if you want to learn a little bit more about integration and operationalization, that will be our Integration Works link. If you want to learn a little bit more about what Julie spoke to earlier around integration and sleep health or integration with diabetes, you can click on the sleep and diabetes links. These are some SAMHSA sponsored series that cover these topics in more depth. And it looks like we have some questions. I don't know if we want to launch right in.
Yeah, thank you so much. And we started a bit late. So how about, I'm happy to read the question, if that would work. So what resistance, if any, do you see working in integrative settings in reference to a client declining the spectrum of services available? For example, an individual coming in for a primary care appointment, having resistance to behavioral health referral, say perhaps due to stigma of mental health services or related reasons. When that resistance does arise in any case, what does navigating that conversation look like with the client to encourage engagement in services, particularly for high intervention clients truly needing the spectrum of services? Great question. And it's a long one, so I'm happy to see if I can put it in the chat as well.
Perfect. No, I've got it open here. Julie, do you want to start or do you want me to?
I can go ahead and start, and we'll tag team. And I think this is the power of integrated services, in which you're not asking someone to stop try and make a referral, make the phone call later, go to a different building, a building that might say behavioral health, that would, if they do have concerns about going to behavioral health or have any stigma that's on the side of the building. So that goes back to that no wrong door comment I have. So really just integration in and of itself almost sets up a dynamic where you're reducing some of that, but this is a fantastic question. It also sets up the teams when they're coming together for integration generally work on this as well in terms of having conversations with patients around what is it about behavioral health that's stopping you from wanting to move forward, motivational interviewing, other conversations and techniques to find out what is it personally that the idea of engaging with a behavioral health provider is stopping you from wanting to do that. And we can bring this into our next presentation as well somehow and answer the question, but I'll turn it over to you, Kristen. And I know we have another question and maybe we can bring that into our next presentation as well.
Perfect. Thank you, Julie. So Sarah, I guess the first thing I would say is to acknowledge that not everyone who might benefit from a behavioral health referral is going to take that referral. And there is a degree of acceptance that when you're within an integrated care setting, exactly like Julie just said, there's an opportunity to talk about that behind the scenes and make sure that your partners in that care, so your primary care provider in this instance, is actioning motivational interviewing and really understands how to tee up a visit with a behavioral health provider. Sometimes we find that folks do respond to the words we use, right? So instead of saying, do you want to talk to a therapist, saying, wow, it sounds like, things have been a little rough lately. Have you thought about, just having a conversation with someone, and really making sure the primary care provider is using non-stigmatizing language. There are also some other pathways to behavioral health that are opportunities to sort of move folks along. Let's say, a trans-theoretical model of pre-contemplation of behavioral health to, hey, I'm actually, actively in a relation, I have a therapist that I'm working with. And those can be group therapies. And an example of that is an organization who was providing a lot of care to veterans. And what they found success with was asking folks to join a veterans guitar learning group. And then folks from that group, through the conversations they were having, became more warm to the idea of having a conversation one-on-one with a therapist. And so it is also what navigating that conversation can look like is figuring out what's comfortable to that client and letting that client have the autonomy to engage in the care that they are ready to engage in. I will claim, just for myself, I come from a harm reduction perspective on this. And so it is letting someone self-determine what they are interested in and what would work best for them, but also having the services available to meet their need should they raise their hand at some point and say, hey, I do want to navigate this one with someone at my side who's a behavioral health provider. And it looks like we have an additional question that's come in here. I can just go ahead and read it if that's helpful for timing here.
That's up to you. I know we're at 12:01, but if you can answer it, we'd be thrilled.
Yeah. So this question is, how would you recommend explaining the importance of identifying possible comorbidity, both of mental, emotional, and physical issues, to primary care providers? And then secondly, how would you go about explaining how trauma is stored in the body and how that is seen when these clients have an appointment with their PCP? I love this question. So I'm gonna try and briefly answer this. I'm not sure if everyone who's on the line is able to stay. I'm able to stay and speak to this. But if other folks, including folks, my fellow presenter or anyone else who's here with the team, needs to hop off while I speak to this, I completely understand. We are over time. So I'll start firstly with the second one. I would start by asking questions to that primary care provider about their understanding of trauma. I would start by using examples perhaps of the crossovers and intersections that we see between the physiological and the psychological. And we know that psychological symptoms can manifest physically, and we know that physical symptoms can manifest psychosomatically. And inviting that primary care provider to start naming those can be a really powerful beginning to the conversation. And then diving into what is that opening? Where does that primary care provider acknowledge that, for instance, yes, they have a 15-year-old patient named MJ who has asthma and also might have panic attacks, and maybe these things are connected, and that's an opportunity that you can be invited in to say, yes. So oftentimes when clients, have, trauma or something going on, we can push further and identify that perhaps this individual might have physical manifestations of these things. And then you can sort of, backtrack and forth and say, sometimes if someone reports an injury, they might have gotten that injury and they don't know how, they might be dissociated. So they might have trouble feeling their toes, and they might have walked into a wall and not noticed that they hurt their toes until a couple days later, and that has been exacerbated. And so let's have this conversation around what that can mean. And I'm not saying this is, the end all be all of ways to have that conversation. I think that many of you on the line, as I'm saying this, are figuring out in your head better ways to have that conversation. And that's kind of the point to my answer to this question. It's just about figuring out how it works for you and you feel comfortable starting asking questions of your primary care colleagues, because they can learn from you and maybe put some pieces together on clients who just aren't getting better, that maybe they're just not treating all of what that person needs. I don't know, Julie, if you want to add anything to that.
I would agree with everything that you said. And I would also say that clinicians and PCPs also resonate with research and bringing that in, and also resonate with support related to examples of how to have conversations with patients. So if you can model how to have a conversation, how to introduce, maybe some role playing in that process. Also use other team members, because it could be that there are other team members that can introduce this as well, and they might introduce it better than the primary care physician. So if there's nurses or care managers or some other staff members in different roles, be strength-based, as Kristen mentioned, with the team members as well. That is certainly acceptable also.
Thank you, Julie. And to the first part of your question, I would actually reference, and I think that's kind of why we started with the second part, asking those questions and then getting to that importance of recognition that comorbidities exist across the spectrum of mental, emotional, and physiological. So to Julie's point around research, SAMHSA has the Substance Abuse and Mental Health Services Administration has some phenomenal resources around how the mind is connected to a lot of other aspects of our health. And we have a lot of correlations between depression, anxiety, discrimination, and heart attacks and shorter lifespans. And that's sort of irrefutable evidence of the very possible, very much happening comorbidities that a lot of the individuals that you will provide care to throughout your career are living with, from the time that they are adolescents through the time, that follows the trajectory of the rest of their health. So having that conversation, asking that and assessing, is that, provider, that primary care provider, open and acknowledging of this? And can you really speak deeply around these intersections? Or as Julie was saying, is that an opportunity to maybe bring in someone else? You don't have to go it alone. We're not asking you, you can be a champion, but we all need a break sometimes, and finding other folks who might be able to have that conversation or join you in that conversation so that the primary care provider you're interfacing with has an opportunity to learn from what you're offering. SAMHSA also has sort of the dimensions of wellness wheel, which I'm sure folks here are aware of. I think there's 7 or 9 dimensions of wellness. And again, that can be really helpful in starting the conversation and even inviting primary care providers to start identifying those with clients. And I've helped some primary care providers become more open to having those conversations just by saying, hey, fill this in with your client. What's their dimension of wellness mentally? What's their dimension of wellness financially? And just starting that conversation to help, your fellow human who happens to be a primary care provider recognize and acknowledge some of what they might already know, but not be interfacing with regularly at the level of awareness that you've been trained to have, because they had a different training.
Kristen and Julie, I know that we went over time, and I just want to let you know how much we appreciate your time today. And just this was such a tremendous overview and thorough review of the basics of IBH, and really appreciate you applying it to kids and talk about their conditions and the case scenario. And I think these 2 questions that we got, we could have talked about for hours. So I appreciate you staying on and really addressing trauma and ways to interact with primary care providers. So I know we're way over time, so I want to say thank you to both of you, and thank you to all who attended. And we look forward to part 2, which for all of you still on is October 29th on Thursday at 11 o'clock. So we look forward to part 2 of this.
Thank you all so much.
Yeah.